Hello, everybody. My name is Allison Fortin, and I'm going to be discussing research conducted by Clooney et al. In 2019. This research was in the journal Cell, Host, and Microbe and has an impact factor of 20.6 as of 2023. And the research title is Whole Virome Analysis Sheds Light on Viral Dark Matter in Inflammatory Bowel Disease. So, what is inflammatory bowel disease? IBD is an umbrella term for chronic conditions that cause inflammation within the digestive tract. There are two main forms of IBD, and that is Crohn's disease and ulcerative colitis. Crohn's disease is any component of the GI tract from your oral cavity to the anus and involves all layers of the gut. Ulcerative colitis only affects the colon and primarily confined to the mucosal and submucosal compartments. Most people who get IBD are diagnosed before the age of 35, but there are some who don't get the disease until later in life. The cause of the disease remains unknown, but there are some factors that may aggravate it. So one possible cause is the change in function of the immune system. When our body is trying to fight off a virus or a bacteria, a different immune response causes it to attack the cells within the digestive tract as well. There are several genetic markers and genes that have been associated with IBD, and it's usually more common in people who have family members also with the disease. There are some environmental triggers: being raised in a sterile environment, limited exposure to germs, GI infection early in life, taking antibiotics within your first year of life, and there could also be diet. So diet could play a factor as well. Long-term dietary patterns affect the ratios of bacteroids, Prevotella, and firmicutes. So here we have a list of IBD symptoms, and this could include all or some: diarrhea, abdominal pain, abdominal cramping, blood in your stool, loss of appetite, weight loss, fatigue, nausea, the urgency to have a bowel movement, constipation, and the increased risk of colorectal cancer. There are a few tests that can be done to determine if a patient has IBD. First, a blood test will be done. This does not confirm IBD, but it will rule out conditions that cause other similar symptoms. Stool test could be done to rule out infections, check for blood, and assesses the severity of the inflammation of the gut. Endoscopic procedures are performed to provide a detailed view of the GI tract. This will help doctors diagnose IBD and differentiate between Crohn's and ulcerative colitis. The intestinal lining is observed for inflammation, ulcers, and they will take biopsies as well. Imaging can also be conducted to reveal tears, bleeding, inflammation, or an obstruction within the GI tract. As for the global impacts, there is a rising prevalence worldwide, particularly in developing countries, and it affects women twice as often as men. It's pretty common. It occurs in about 15% of the US population and impacts the quality of life because symptoms. And the burden on the healthcare system due to long-term management, medications. There is a greater need for additional research to develop more effective treatments. There are a few research questions regarding this study. So how does the virome composition vary between individuals with Crohn's disease, ulcerative colitis, and between healthy individuals? What role does viral dark matter play in these changes? And does gut virome and irritable bowel disease individuals show an increased number of temperate bacteriophages? So starting off with our bottom line up front, so why is this research important? So researching the gut microbiome is important as it expands our understanding on how the gut microbiome plays a role in human health. and that will give us insight to more advanced treatments, gaining additional knowledge, and understanding the viral dark matter that is unknown today. So our main research question is, how does the human gut microbiome change in those with inflammatory bowel disease, and how do these viral shifts cause disease progression? So what researchers found is that there are significant virome differences in irritable bowel disease that reflect bacterial composition changes. Healthy individuals have a virome of virulent bacteriophages, whereas those with IBD have an unstable virome that is disrupted by temperate bacteriophages. Virulent bacteriophages infect bacteria and kill them through lysis, and temperate bacteriophages are lysogenic phages and disrupt the gut microbiome balance, which leads to IBD. The authors answer the research question by using metagenomic sequencing and 16S rRNA sequencing, revealing that those with IBD had a much higher abundance of temperate bacteriophages. They focused on the viral dark matter, and they used functional gene analysis and CRISPR spacer matches and identified a shift from virulent to temperate bacteriophages in IBD patients. The metagenomic approach allowed the authors to view IBD alterations in the gut virome, showing how temperate phages further progress the disease. Virome analysis allows for disease classification and improved the ability to differentiate between IBD and healthy patients. So this suggests new biomarkers for IBD. The correlation between virome and bacteriome changes. An increased number of temperate phages correlated with bacterial disruption in IBD. And the CRISPR spacer showed many temperate phages in IBD had bacterial hosts belonging to firmicutes, which are known to be depleted in IBD patients. And this supports the idea that the increase of temperate phages contributes to bacterial loss and microbiome instability in IBD patients. The study reanalyzed a previously published IBD virome keystone dataset that consisted of 165 gut virome samples from 130 individuals. 61 of these individuals were healthy, 27 had Crohn's disease, and 42 had ulcerative colitis. Of these, 6 were known to be collected during Crohn's disease flare and 8 in Crohn's disease remission, and 13 in ulcerative colitis flare and 20 in ulcerative colitis remission. And then the viral DNA was extracted. An additional in-house dataset was collected from a longitudinal ulcerative colitis cohort, which consisted of 40 subjects. And this was to analyze the virome changes over time during these periods of flare and remission. The patients were analyzed was determined by the Mayo score, and the Mayo score is a disease activity index used to measure the severity of ulcerative colitis. It's essentially a questionnaire. And the stable versus fluctuating viral clusters were identified to assess whether the virome changes were consistent across these disease states, the flare and remission, and you will see these viral clusters in a few more slides. And then 16S rRNA sequencing data was also used to collect for bacterial community analysis. So now we're going to begin talking about all the figures of this research. This research had a lot of figures, so I'm going to try to go through them as best as I can. So figure A and B are showing the pre and post clustering of principal coordinate analysis. So figure A on the left is the pre-clustering, and it uses Spearman distances to show the beta diversity, which is the variation of the virome composition of these viral-like sequences across the groups. This figure shows no clear separation between these three groups, making it difficult to identify the IBD patterns. The lack of separation suggests that a higher level clustering approach is needed to allow for further grouping into broader taxonomic groups for further clarification, and we can see that in figure B. So this analysis is based on viral clusters and is much more distinct, and we can see these disease-specific patterns are much more visible. So grouping viral sequences into higher taxonomic rates reduces the noise, and we can see the correlation between health and disease. And we can see on the axes PC1, which is on the bottom, and PC2, which is on the side. The variation has more than doubled in figure B in comparison to figure A. So we can see PC1 in figure B is 10.36%, and figure A is 4.85%. And PC2 on figure B is 5.58%, and PC2 on figure A is 3.59%. And this increased variance suggests that IBD signals are much more apparent. Figure 1, C, and D shows the relative abundance of viral features. So figure C on the left, the top graph is the shared viral contigs, which are the controls, in the controls, and then the bottom graph is the shared viral clusters in the controls. So at the VLS level in the top panel, the figure shows most viral sequences are unique per person, showing only a minor amount shared across the subjects. And about 14% of the viral sequences are unique to a single person. And sequences shared across 30% of individuals make up about 1.7% of the total virome. No VLS are shared across 50% plus of individuals, and we can see 50% is going to be described in blue, and there is no blue on this graph. It only goes up to about 30%. So this confirms that high variation among individuals covers up the broader virome patterns, and this is making it difficult to identify changes at the strain level. So after clustering, in the bottom panel, it shows the shared viral features increase drastically, reducing the individuality and showing better comparison across the cohorts. So about 1.3% of the viral clusters are unique to an individual in comparison to 14% for VLS. The viral clusters shared across 30% of the cohort make up about 15% of the total virome in comparison to 1.7% for the VLS. And about 7.1% of the viral clusters are shared across 50% of individuals, which again is our blue here. And you can see there's much more blue on this graph. And this is not shown at the VLS level. This confirms that clustering viral sequences into broader viral cluster groups shows a much more stable shared analysis of our virome. So in conclusion, using viral clusters rather than VLS shows for a stronger cohort comparison and identifies a core virome that can differentiate health and disease. So now we're going to look at figure D on the right, and this is the number of shared VLSs versus VCs across the cohort. So this is going to show our viral clusters shared across 30%, 50%, and 70% of individuals in each cohort. So at the VLS level, almost no sequences are shared across the individuals, reiterating that individuality of the viromes. And then at the VC level, the core set of shared viral clusters shows mostly in healthy controls, suggesting that a stable virome exists in those without IBD, but shows the virome is disrupted with IBD. So the key takeaway from figure 1 overall is high individuality of the virome at strain level resolution covers disease-specific patterns, and clustering shows common viral features within our core cohorts. And a core virome is presented in healthy individuals but is disrupted in our IBD patients. And virome alterations in IBD have a parallel shift observed in bacterial composition, suggesting a link between these bacterial and viral microbiomes. Figure 2A is showing the Spearman distances that shows the differences between virome compositions between each group. And as we can see, the Crohn's disease and ulcerative colitis viromes are drastically different, and they yielded the greatest degree of separation between viromes of Crohn's disease patients in relapse and remission and healthy controls, followed by UC relapse and remission. So the separation between flare and remission states is minimal, but this could be due to the small sample size. And this also suggests that Virome alterations in IBD patients persist regardless of the disease state, meaning the viral composition may be a stable feature of IBD. The PCOA without the division of relapse or remission status showed that Crohn's disease and ulcerative colitis beta diversity significantly differed from the healthy controls. 2, B, and C are showing the viral clusters and alpha diversity. So figure B on the left shows the overall virome diversity, and it shows no significant difference in virome richness across the cohorts or disease states when viral clusters count tables were used. So the Wilcoxon test value for C flare versus remission had a p-value of 0.31. The ulcerative colitis flare versus remission had a p-value of 0.96, and the Crohn's disease versus healthy had a p-value of 0.12, and ulcerative colitis versus healthy had a p-value of 0.083. So figure C is showing observed viral clusters in cardiovirals. Please excuse me if I am saying that wrong. And these were considered, and a significant increase in richness was observed in Crohn's disease versus healthy only controls. So the Wilcoxon test value had a p-value of 0.024, and this suggests that changes in the composition of identifiable fraction of the virome may not reflect the virome as a whole. Figure 2D is showing that Crohn's disease has a significantly higher abundance of temperate bacteriophages than the controls, as we can see. And the Wilcoxon test value is 0.012, and this supports that the study's finding that IBD, especially in Crohn's disease, is associated with a shift from virulent to temperate bacteriophages. 2, E and F shows volcano plots showing viral clusters are differently abundant between Crohn's disease and the controls, which is E, and ulcerative colitis and the controls, which is F. Everything below that red dotted line you see at the bottom is insignificant. And with both of these figures, temperate bacteriophages, which are the Scipioviridae and the Myoviridae, are increased in IBD. And virulent bacteriophages, which is the Microviridae and Cras-like phages, are much more abundant in the controls. So most disease-associated viral clusters are still unclassified, which are all the black, and that shows that viral dark matter is still prevalent in IBD. So these findings also support the increased cardiovirals richness observed in Crohn's disease, and 17 of the Scipioviridae viral clusters increased in IBD relative to the healthy, and 15 were classified as temperate and had CRISPR hits to firmicutes. So these observations correspond with the reduced firmicutes abundance observed in IBD patients. Figure 3A and B is showing another principal coordinate analysis of the 16S bacterial beta diversity. So this one is showing, figure A is showing the unweighted unifrac distances to show the differences in bacterium composition between the groups. And the bacterium also differs between patients with IBD and controls. So bacterial beta diversity was assessed through 16S rRNA gene fragment sequencing, showed that Crohn's disease, relapse, and remission samples had the grouping furthest from the controls, and we can see that. Let me get my pointer. So here is the UC flare, and the light blue is UC remission, and the green is the controls, and then this is Crohn's over here. So the Permanova values are P equals 0.018 and P equals 0.001, which was reflected in the virome composition. And Crohn's patients, as we can see, showed the greatest deviation from the healthy controls. And this shows a much more severe microbiome alteration in Crohn's than ulcerative colitis and the healthy individuals. So figure B is showing alpha diversity, and it's the 16S CHAO1 diversity, richness in bacterial species. And this graph shows that Crohn's patients in both flare and remission have lower bacterial diversity than the controls. So the Wilcoxon test p-values are 0.012 for flare and 0.018 for remission. So ulcerative colitis patients also showed a decreased bacterial diversity, but the difference is less pronounced at 0.051. And this graph suggests that gut bacterial richness is reduced in IBD, specifically in Crohn's. 3C and D is showing another variation of volcano plots, and these are showing bacterial taxa in Crohn's versus controls and ulcerative colitis versus controls. So figure C is going to be Crohn's and figure D is going to be ulcerative colitis. So a total of 113 ribosomal sequence variants were decreased in Crohn's versus controls, while only 17 were increased. In ulcerative colitis, 69 were increased in controls versus ulcerative colitis, and only 21 increased significantly in ulcerative colitis. So many of the taxa increased in controls versus both IBD cohorts. So this is proving that IBD is associated with a significant gut virome composition and showing specifically that Crohn's shows the most alteration. And bacterial diversity is lower in IBD, specifically in Crohn's. Is showing the viral and bacterial drivers of beta diversity separation. So figure A on the left is showing the viral clusters with Spearman distances again, and this contributes to virome composition changes in IBD patients. Beta diversity was assessed through correlations between principal coordinates and the relative abundances of VCs for the virome and RSVs for the bacteriome. And there were 25 VCs that significantly correlated to PC access 1, where the Spearman p-value was less than 0.05. So in quadrant 1, let me get my pointer. Oops. Quadrant 1 on the top left, there were 18 significant correlations that were comprised of Scifioviridae and Myoviridae VCs and many other unclassified VCs. So in quadrant 3, Myoviridae and one unclassified were significantly correlated towards subjects with IBD. The viral clusters classed for Mycoviridae and Cras-like phages, and two unclassified viral clusters were significantly correlated towards healthy controls. And this provides further evidence that a shift from a virulent core of Cras-like phages and Mycoviridae to one of the primarily temperate phages may be associated with IBD. So on figure B on the right, there were 76 bacterial RSVs that were significantly correlated towards the controls, and the highest correlation coefficient corresponded to RSVs assigned to the phylum Firmicutes, and we can see that here. So quadrant 3 correlations also towards the controls contained 46 RSVs, including, I'm going to butcher these, I apologize, Allostipes, Indistinctus, and the order Clostridales. I do apologize about that. And then for quadrant 4, towards IBD patients, 4 RSVs were significantly correlated, including the Ruminococcus and I don't know how to say the word, Flavinofractor. species. A and B is showing the differences in virome during UC flare and UC remission. So this is using beta diversity analysis. So figure A on the left is showing a principal coordinate analysis based on Spearman distances yet again. And as you can see, there's no significant separation between UC flare and remission. It has a p-value of 0.17, and this suggests that the overall virome composition remains relatively stable between these two states of flare and remission. So figure B is showing a similar analysis for 16S bacterial composition. And as we can see, there is a significant shift between flare and remission that has a p-value of 0.022. And this indicates that the bacterial community structure changes more noticeably than the virome. Images C and D is showing the alpha diversity analysis between UC flare and UC remission. So as we can see, there really is no significant difference in diversity between these flare and remission states. Higher viral loads were associated with lower viral diversity, and viral diversity did not change significantly over time or with disease status. So figure 5, E and F is a continuation of UC flare and UC remission, but these are the volcano plots. So as we can see, UC remissions on the left and UC flares on the right for both graphs. It's just showing different phage groups. So figure E is showing the viral clusters, and on the remission side, we can see that there are crast-like phages, which is going to be the purple, 2 Scipioviridae, which is the blue, and 1 Mycoviridae, and 7 unclassified phages were much more abundant in the remission group. And on the contrary, 39 viral clusters were increased in flare, including 2 Anelio Viridae, 1 Myoviridae, 10 Scipioviridae, and then 24 unclassified viral clusters. So figure F is showing the bacterial taxa again. And as we can see on the left in the UC remission side, that is showing bacteroides, and Dialister. Please forgive me. And we can see that these groups are increased with remission state. And then whereas on the UC flare side, we have Enterococcus, which is down here, Prevotella and Streptococcus and a few others were much more abundant in the flare state. So these findings suggest that the changes in virome composition between flare and remission reflect those of the bacteriome and are much more stable than those observed between UC and healthy cohorts. 6, A and B is showing virome-based classification, and it shows the top 20 viral clusters that contribute to IBD patients versus the controls. The accuracy in distinguishing IBD from the controls is 76.9%, and that's shown down here. And that's indicating a statistically significant predictive power. So 4 of the top 5 contributors based on gain is VC39, VC23, VC38, and VC45, which are the top 4 green ones. And these were increased in controls versus the IBD states. And these were the most significant clusters and their bacterial hosts that are associated with a healthy microbiome. And most of these clusters, as we can see, are unclassified, showing the importance of including viral dark matter in virome analysis. These results support the idea that healthy individuals have a much more stable virome, whereas IBD individuals have an increased presence of temperate bacterial phages. So figure B is only using bacterial taxa and 16S RSV, and this has an 82.4% accuracy. And as we can see, I'm not even going to try to say this, and Clostridiales are drastically increased in the controls, but they're decreased in IBD. And there are a few others here. that are increased as well in IBD. The bacterial microbiome alone is more accurate than the virome analysis in predicting IBD, and the results continue to confirm that IBD is strongly associated with the reduction of beneficial bacteria and increases in pro-inflammatory bacteria. Restraints, I'm just going to very briefly go over these two figures. So figure C has an 85.3% accuracy, and this is just showing that combining bacteriome and virome improves classification accuracy. And it's much more accurate, suggesting the strong link between the two. Figure D is a receiver operating characteristic curve, which looks at the sensitivity of each model. And this graph just shows that the virome alone is useful, but not as accurate than the bacteriome for predicting IBD. However, it is a stronger correlation when virome and bacteriome are put together. It is the most accurate prediction of IBD, showing that they both play a critical role in gut health and disease. Showing a network plot of CRISPR protospacers to the 20 most relevant viral clusters. And each viral cluster is linked to its predicted bacterial host based on these CRISPR protospacer matches. The connections show CRISPR protospacer matches signifying a host phage interaction. And this shows which phage bacterial interactions are more active in disease versus healthy individuals. So this chart shows that IBD is characterized by a shift in bacterial phage host dynamic, which increases in temperate phages. And healthy individuals have a core virome dominated by virulent phages, which supports gut homeostasis. And CRISPR-based host predictions show that many unclassified viral dark matter phages are here, and it shows complex interactions between viruses and bacteria within the gut, proving the change in virome mirror the shifts in the bacteriome. Conclusion, healthy microbiomes were found to be dominated by virulent bacterial phages, whereas IBD microbiomes are replaced by these temperate bacterial phages. And this is linked to bacterial dysbiosis. And whole virome analysis showed distinct changes between these healthy individuals and IBD individuals. And it showed an increased number of temperate phages correlating with bacterial community disruptions. And this improves disease classification and helps us greater understand viral dark matter. And overall, the study provided strong evidence that virome composition plays a crucial role in IBD. After doing this presentation on IBD, I still had a few questions that I had left unanswered. So number one, how does early life exposure to bacteriophages influence the risk of developing IBD? So do differences in the gut microbiome during infancy contribute to immune system development and susceptibility in IBD in adulthood? And number two, is there a tipping point in microbiome instability? So since the gut virome changes with IBD progression, at what point is it considered healthy to where it becomes a problem where the viral shifts drive instability? Number three, is bacteriophage therapy a treatment option to eliminate these pro-inflammatory bacterial populations in IBD patients? Is there a treatment to restore our gut balance, basically? Number four, how do viruses contribute to IBD pathogenesis? This study focuses on bacteriophages, but what about viruses like norovirus, and how do they affect the virome imbalance? Number five is, how long would it take for the gut microbiome, if at all, to return to a normal healthy state? Is it possible for constant reintroduction of healthy bacteria into our gut for the gut to return to a healthy, normal homeostasis state without any flare-ups? Thank you guys so much for listening to my presentation. Feel free to ask any questions and chat with you guys soon.